There's a Q&A section at the bottom. If you're watching on Facebook, you can write that right in the comments as well, and we'll make sure we get to those at the end of the session here. Oop, there we go. Now, before we get started, I want to talk to you a little bit about where this information is coming from. So in clinical practice, we have these things called clinical practice guidelines, which are essentially an overview of all the current literature in regards to treatment for a specific process or injury. Okay, so how they work is there are researchers who compile all the available studies on a certain topic or injury. So in this case, sciatica, and they'll look at all different types of treatments, assessments, medical management, pain medication surgeries, that kind of thing. They'll look at all of the studies out there and they'll rank them based on quality of evidence. They'll rank them based on the strength of the study, feasibility, financially and time-wise. And what they'll do is they'll use all these rankings and they make recommendations based on all the studies on what is the ideal outcomes for people or the ideal treatment strategy. Now, these studies, what they do is they influence the way we treat patients and the way we suggest the most effective care. Now, where we find those things oftentimes is the American Physical Therapy Association. Now, that is the professional organization for physical therapists across the United States, and they will direct therapists to clinical practice guidelines for patients with issues and injuries. And the specific one that I'm using today was created by the National Institute for Health and Care Excellence, which is a research organization in the United Kingdom, and they exist solely to improve outcomes for the National Healthcare Service. So they work with their government agency to improve outcomes for patients with all types of injuries, specifically in this case, sciatica. And the study, if you wanted to learn more about it, is called Low Back Pain and Sciatica in Over 16s, Assessment and Management. And now it was initially published in 2016, looking back at all the research before that date. It was also just updated in 2020 with all the research that has been done on sciatica and low back pain since 2016 to 2020. So all the guidelines and recommendations that I'm going to be providing in this video here today will be up to date based on that 2020 date when they were reviewing over that literature. So now, the first question here would be, what is sciatica? So sciatica is an irritation of the sciatic nerve, which is a nerve that runs from the low back all the way through the hip, down the back of the leg, and into the actual foot. So it basically transverses the entire length of the leg. Sciatica it's a term that describes a neuropathic or a nerve pain that radiates into the legs. Oftentimes it's caused by a compression or irritation of nerve roots in the lumbar spine, the low back, or anywhere along the length of that nerve from the hip all the way into that foot. Now, it is extremely common to have an irritation of that nerve. Most people are going to have that throughout the length of their lifetime. So it's not to be unexpected. However, there's often no long-term issues that occur because of it. And the prognosis or outcome is usually very good. Most people will find that their symptoms will clear up without any treatment at all. However, there are still a lot of more serious issues that can arise from it that we want to make sure will take a little bit of extra management to clear it up. Which brings us to our first myth, and that's that sciatica is a diagnosis. So sciatica isn't really a diagnosis, it's more of a set of symptoms caused by another medical issue, which we'll cover quite a lot in the coming slides here. There's a number of different issues that can cause it, and like we said, as we go through the pathway, that should become apparent as we start talking about all the different areas that can become irritated or inflamed. So let's take a look at the actual pathway here. Now, if you look at the bottom here, if you guys can see my mouse here, as I circle around, that's the start of where the sciatic nerve forms. And in this point, they're all called the spinal nerve roots. So as they leave from the spine here, all these little different parts coming out of the spine there, they're all lumbar nerve roots. And then down here, they're sacral nerve roots. So once those exit the spine, there's a large mesh of nerves in this area, and they basically run and they innervate all of the leg. Now, the ones we're most interested in here are coming into this area, and they're all kind of forming in this spot called the sciatic nerve. That's where it forms. Then it leaves through the pelvis out the back here beyond that hip bone. And then if we're looking at from the back here, it comes out through there. It runs down the back of the upper leg here. And all these little branches here go to different muscles, basically. So they innervate all the hamstrings. It innervates all those muscles. It controls the ones down the back of the leg. Now, it does also come down here below the knee, and it starts to branch into a couple other nerves that are also of interest in sciatic pain, the tibial nerve and the peroneal nerves. Now, as we look at the lower portions here, we see those branches do run all the way down the side of the leg, down the foot, and to the end of the foot. So it innervates everything along that leg. So symptoms of sciatica, if we're looking at irritation of that nerve, the biggest thing we're going to have is pain. Okay, so pain in the whole length of that nerve, as you can see here, down the whole back of the leg. So in the lower back, the hip, the leg, the foot. It's possible in all those areas that are innervated by that nerve. Another common thing is changes in sensation. So we might get some numbness, some tingling, a feeling of potential weakness or loss of strength. Those are all common with that irritation and the issue with the nerve as well. Now, the actual pain symptoms can be widely spread and varied. So they can go anywhere from mild aches to severe aches. It can be sharp pains, shooting pains, burning. Those kinds of sensations are all possible. Typically, symptoms are only going to appear on one side of the body and one leg. If they do occur on both, we might be more concerned about a more serious injury to more the central spinal cord, right in the actual lower back there, versus an irritation down the nerve. Which brings us to our second myth, that all shooting leg pain is sciatica pain, and that is not true. Okay, the sciatic nerve, while it does innervate most of the leg, the entire back of the leg, and just about everything below the knee, we have additional other nerves that run down the front of the leg. So if we have shooting pain down the front of the leg, it's probably not the sciatic nerve. There's a nerve there called the femoral nerve, which would be of interest in that instance. Also, there are a lot of other issues, muscle issues, and other structures in that area that can create pains very similar to nerve pain in the leg, but are not necessarily due to irritation of that nerve. So it's important to talk to primary care or physical therapists to differentiate between that and make sure that you do actually have what it looks like you have, if it is sciatica or if it is something else. So I want to talk about next are the types of irritation that can happen in nerves. There are two main classifications that we have. And the first is a mechanical compression of the nerve roots or the nerve. So that's where there's actually a constriction on that nerve. And what will happen is that nerve will actually begin to die because of that pressure. Okay, that constriction doesn't allow nutrients to travel down the nerve, and it will cause it to lose the ability to maintain that essentially maintain life, right? So it's those kinds of things that can cause that to happen are bulging discs if they constrict the nerve to a point where it leaves the spine. If it creates enough compression, it can start causing those symptoms. Bone spurs, if they're formed in the wrong areas, will also potentially constrict that nerve to the point where it can cause that lasting damage. Now, other options are where muscles run through or around that nerve. If the compression is great enough there, it can cause the same type of symptoms. Now, those things, before they cause enough of that compression, they can cause the second kind of irritation, which is more a chemical or mechanical irritation. Now, with that, either a chemical or a tensile stress gets placed on the nerve. So if there is a herniated or ruptured disc, there is a liquid inside the discs that can leak onto the nerves, which is actually a neurotoxin and it will irritate those nerves. We'll talk a little bit more about that later. There is mechanical tension of the nerve. So if there is a sudden tug on the actual nerve, that can create irritation and inflammation and create those pain symptoms. Also, entrapment of the nerve. So if it's trapped somewhere, either between rubbing over a bone spur, trapped between muscles, if there's some kind of thing that's restricting that nerve, that's going to give some more stretch on it, and it can irritate and inflame the nerve, causing those pain symptoms as well. Now, it's important to note, we can have both that mechanical compression and the chemical and mechanical irritation at the same time. And the way you treat those is differently, and what you can do with each is different. So it can create an interesting case or a challenge to resolve if you do have both things going on at once. So the next question is kind of, what type do I have, right? We know there are two kinds. How do we tell the difference? So the first kind, where there's the actual compression, we tend to call it a radiculopathy. So we tend to call it radicular symptoms. Oftentimes that occurs very close to the spine. Most of the pathology that would occur is in the spine that would cause those compressions to happen. So what we'd feel in that instance was a change in sensation as a loss of sensation. So we might have numbness, we might have a decrease in sensation, where you actually can't feel if something pokes you in a certain portion of the leg. We'd have change in reflexes and actual loss of reflexes in the quadriceps and hamstrings at the knee, or at the actual ankle and the Achilles tendon. And typically what we'll find is a loss in the actual strength of the muscles. So to the point where it also affects our coordination, but it's more of a strength issue. The second kind, where it's more the irritation, is more of what we call the neuropathy, which is just that nerve pain or the irritation of the nerve, inflammation, and makes it more sensitive, more irritable to any input or any sensation that gets put through it. So it's going to increase the level of sensation. We might be hyperactive or hyper-responsive to pain. Even a light stimulus, light pressure might cause pain when it otherwise wouldn't, because the nerve's been sensitized or increased in sensation. Also, we'll have an increased reflex response because those nerves are irritated, they're hyperactive. Any of that input will trigger that reflex response a lot quicker, with a lot less force going through the tendon in that stretch. Now, what we'll oftentimes find here is that we'll find some motor weakness in terms of coordination loss also, because in that tensile stress, what happens is our muscles will actually sometimes protect or try to protect the nerves. So they'll contract and constrict and potentially create muscle tone, which will limit our ability to move. They'll limit the movement of that nerve, and they'll limit their ability to coordinate with other muscles. So we might notice something where it feels like our coordination or strength is off. We might feel a little bit weak in this instance. However, what we'd notice is the muscle strength of each individual muscle is good, but they can't work together. Which brings us, so now we know what type we have. We kind of have an idea of what types the symptoms are. Another common theme that people oftentimes use is they'll talk about imaging, and they'll think, oh, if I get the image, I'm going to know for sure what I have. Well, that would be a myth. Imaging isn't going to explain your pain. A picture can say a lot, but it can't tell you where pain comes from, because pain is a very complicated topic. And there are so many factors that influence it, from stress to actual irritation of the nerve or the peripheral irritation of muscles and other tissues out there. It's impossible to state where it comes from. And there's a number of spinal structures that are supplied by sensory nerves and are capable of that pain generation. And there really isn't any clinical features that are reliable or imaging findings that are reliable in terms of allowing us to identify the specific cause with any sort of confidence. So if someone is looking at a picture of an MRI or an X-ray and they point at and say, this is where your pain is coming from, they're guessing, okay? There is no consistent finding that can tell us where that pain is coming from. Yeah, they might see something, and if they point to that spot and say, okay, here's an issue here, your pain's probably coming 1 or 2 segments above or below that. That's a much more accurate representation, and it can create a lot of confusion and irritation with people not getting better from more invasive procedures if they don't have the right area localized and locked down. So in the case of sciatica and lower back pain, X-rays and MRIs really are not recommended unless there is a sinister pathology or a number of red flags that would potentially create an issue or a reason for concern that they want to look into, or if it's likely to change routine care from regular exercise and restoration of movement to combat this issue. Now, those red flags or reasons for concern, there are a few of them. So especially with spinal issues and nerve issues, we want to be aware of any changes in the bowel or bladder function. So if all of a sudden we lose the ability to control our bowel or bladder function, that's going to be a very significant red flag of a potential spinal cord injury, potentially a stenosis or a cauda equina syndrome, which again is just irritation and compression of those nerves in the actual spine, which is a medical emergency and will oftentimes need a surgical intervention to take care of. Severe weakness or loss of sensation in the legs or groin. Again, if it's bilateral, if it's on both sides, again, it's potentially indicating there may be some type of spinal stenosis, or there may be some type of extra compression, that mechanical compression, which can actually kill off some of that nerve and then cause lasting damage if it's left for too long. Now, another big thing to think about is the unexplained or unexpected loss of appetite or weight. That is commonly associated with cancer diagnoses, but it's important to know that less than 1% of people presenting to primary care with low back pain and sciatica are going to have cancer as an underlying cause. So that's a very low percentage. It's still there. The good news is that our society is very attuned to the red flags of cancer and other serious pathologies, serious diseases. So our screening questions and things will, the majority of the time, catch any of those red flags, and we'll send you for that imaging right away. And we have, if you see multiple healthcare practitioners, multiple, say you're going to a physical therapist and your primary care doctor, each will do that screen, and they should ask those questions, asking if there's any change in bowel or bladder function, or unexpected loss of weight, that kind of thing, because that'll kind of trigger us to sending you to that imaging to make sure nothing sinister is happening there. So now we've covered those red flag things. I want to go back through the different areas where that sciatic nerve can be irritated and inflamed, and kind of explain how a few of those things will work, okay? So I'm going to start off at the spine here. Now, if we look here, each one of these pieces here, these bones here, are called a vertebrae, okay? We have 33 that make up the entirety of the human spine, 7 in the neck, 12 in the thoracic spine, which is that trunk area. We've got 5 in the low back. We have 5 that are fused as the sacrum. And then we have 4 that are fused as the tailbone underneath the sacrum. Those are just little guys. So in between those bones, well, first that bone is made up of 2 different parts. We have the front portion, which is the body. That's a solid piece of bone, okay? So it's like if I close my fist, it's just solid there. This back portion here is called the arch. So we have a solid portion here, and we have an arch here that forms here. Now there's a space right in through this area here. That space is the spinal canal. That's where the spinal cord goes through. Okay, now those stack on top of each other, just as you see in the picture here. Then you see this space here, that yellow portion in there is actually the spinal cord. And in these spaces here are where the nerve roots will leave from the spine. So that small space there is where that nerve exits the spine, and they run to all over in the body, depending on which segments it is, depending on if it's in the neck, the mid back, the low back, that kind of a thing. So that's the spine. In between those in between those bones, we have what are called the discs, which is this area right here, that kind of blue thing there. Those are formed of 2 main parts. The outside of that disc is a connective tissue. It's a dense connective tissue that is a kind of a fibrous coating that doesn't let anything through it, basically. So it's kind of like a ring that's very solid. Now the inside of that portion is a little bit more spongy. It's more of a liquid, and it absorbs impact. So if we put a lot of force up and down through the spine, that compresses through that spine and the force is absorbed in that squishy portion on the inside, and the outside fibrous connective tissue keeps that from going everywhere. Now, with a lot of high-level stresses, high-level impact, or a bunch of repetitive motions, what can happen is those discs can become irritated. They can start to lose the integrity of that fibrous connective tissue around the outside, and the interior portion can begin to protrude, okay, or push outside of that disc. That's what we call a bulging disc, okay? So there is actually, and if you see here, this little red piece, that disc can bulge a little bit, okay? In severe cases, it'll bulge more to a point where it might be able to constrict that nerve root, which can cause irritation and can cause sometimes symptoms of irritation in that sciatic nerve and sciatica. If it's in other areas, it can cause different issues as well. Now, when we talk about a herniated or a ruptured disc, what happens is that connective tissue on the outside of that disc will actually tear, and portions of the more fluid or gelatinous interior material will leak out. That material is actually a neurotoxin, as I mentioned earlier. If that material, I mean, it was never designed to leave the disc, so it was never designed to be free floating in our body. And if it does, it causes some serious issues and irritation on any nerve that it comes in contact with. So it can be a nerve root, it can be the actual spinal cord itself. So it can cause a lot of issues when that happens, and that usually needs to be taken care of right away. Now, some of the other things that can happen here are the bone spurs. So a bone spur is just extra bone formation. Usually it happens because of extra load that goes through the bone, okay? So repetitive loading that exceeds the ability of our muscles to distribute that force around the bones. That can form, again, if it forms in this space here, that can create potentially an irritation, a rubbing point for the nerve, or it can, to its extreme extent, cause that compression again. So if it causes that compression, what happens is that will potentially kill portions of that nerve or start to cause death of the nerve. And that would need to be taken care of in terms of surgically, okay, if there is enough of that compression there. Another portion that we want to consider is spinal stenosis. So as we mentioned earlier, that canal that runs down the back half of that bone where the spinal cord sets can become restricted in space, okay? If there is some thickening of the ligaments that hold the spine together, or there's extra bone formation in that space, it can become more narrow, so there isn't enough space for that spinal cord to happen or to exist without compressing on it. That can create irritation. Oftentimes that's more down both legs. Sometimes it's only a single leg, depending on where exactly it happens and where that bone formation is. So oftentimes a stenosis, if it happens rapidly enough, we'll need a surgical intervention as well, because that's something we're not able to change with exercise or diet or any of the other interventions available to us. Now, two things that can cause other issues that tend not to be as related to the sciatic nerve would be facet joint issues. Now, as we look at the back of this vertebrae here, these connections right here, they actually articulate or attach. They have joints right here between the two vertebrae. Those joints right there are called facet joints. Now, there's a lot of small muscles that are attached to these areas and all these little processes along the back of the spine. And if we have had some type of a trauma or an injury to a specific area of the back, they can start to protect that segment of the back. They can tighten up and create muscle tone, limiting the motion in there. Or what can happen is there could be arthritis formation in those facet joints. And if that formation is enough, it will restrict motion. And once that motion is restricted at one segment, other segments above and below have to work more or have to move more to take up that slack that's put in by the one that isn't moving. And that can cause more movement and irritation of the nerves as well. So that can cause something similar to sciatica or sciatic symptoms. But again, it's something that is a little bit different and has to be treated a little bit differently as well. Now, the last thing here when we're looking at the actual spine is the Sacroiliac Joint. So that's where the sacrum articulates with the actual pelvis or attaches to the pelvis. And we can see that better on the next slide in the next picture here. So right here on the back side, we have, this is the sacrum here, and we have the pelvis. That's the arch of the pelvis, and it kind of is all the way in this area. Right here, where the two meet, is the sacroiliac joint. Now, a lot of things can happen there. This joint has to absorb a lot of impact and force when we're walking. So all the weight of our upper body goes through that spine and through that sacrum here and into that pelvis. Okay, so a lot of forces get transmitted through there. And if there's a change in our biomechanics or how we move, that can tweak that joint just a little bit. And it can potentially create some irritation, especially if it's over a long period of time where we're potentially not moving as well as we should or could. So that's another thing that we have to kind of make sure we rule out. Now, as we look at this sciatic nerve here with all the muscles and things in place here, we can see right here, it exits from the pelvis and it comes down the back of the leg and it kind of goes underneath these muscle tissues to the back of the knee here. That's the upper portion. Now, we always have to be mindful of the piriformis muscle here when it comes to the sciatic nerve, because that sciatic nerve runs right underneath that piriformis muscle. Now, if we have protective tone or tension on this piriformis, that can create some compression, some rubbing, some irritation of that nerve. What can also happen is in a portion of the population, that sciatic nerve actually pierces or goes through that piriformis muscle. So that, again, can create a rubbing or irritation effect on that nerve, creating those symptoms above and below, all the way along the length of that nerve. The other thing we want to know is that as we're sitting, right, we put pressure right on that piriformis. Okay, we compress that area right there, which can, again, help create more muscle protection and tone, which can cause issues. So if we sit a lot throughout our day, that's an area we definitely want to look at and be concerned with. Now, as we look at that nerve as it comes down lower, it crosses underneath these muscles here. So these three muscles here are the hamstrings, okay, as you see right there. That nerve, as it runs down underneath them, there are branches of that nerve that go into each muscle and they control that muscle's functions. They tell it when to contract and when to relax. What can happen is if we have a sudden impact or stretching of those muscles, that can tension or pull and create that mechanical stress on the nerve, and it can irritate that nerve as it attaches to those muscles or as it runs underneath those muscles. Because it's in such close proximity, the nerve will sometimes create extra tension in those hamstrings. So if you have tight hamstrings, if you're sitting all day, you might actually not have tight hamstrings. It might just be muscle protective or muscle tone in those hamstrings that are trying to protect that sciatic nerve against any sudden quick stretches. Because if that were to happen, it would irritate that nerve, because nerves don't like to be stretched. They don't like that tension. And the muscles are going to do everything they can in their power to prevent that nerve from being tensioned. So that's where we see people that have repetitive hamstring strains or hamstring tears, where it may actually be irritation of the nerve instead of just that excessive load to the hamstring. It could be the underlying cause that's driving that injury. Now, another thing to look at here, we talked about that split a little bit earlier, right at the back of the knee here. You see where it branches into two pieces right where my cursor is there. The first portion running right down the center of the leg, it comes just below that calf and it runs down all the way to the back of the ankle here. That is called the tibial nerve. It's a branch of the sciatic nerve. Now with that one, we have to consider the actual calf muscles as well. When we talked about the hamstring where that came down through here, this does the same thing with those calf muscles in here. So it attaches to those calf muscles. And the same thing can happen if we have tight calves. Sometimes it's protective tone, again, trying to keep that nerve from stretching, okay? And as it's trying to keep that from stretching, if all of a sudden we get this big shock there or this big stretch, we can create an irritation of that nerve and potentially create that inflammation and that pain response running up and down the leg. Now, another thing to look at with that and to rule out are deep vein thrombosis. So a DVT is a blood clot, and the majority of the time, or the most prevalent place for those to occur is actually right in the back here. We have veins and arteries that run right up between these two muscle bellies here of the calf. Now, a blood clot will occasionally become lodged in that location, and it can cause a burning pain. It can cause a really deep achy pain, or sometimes a sharp pain, especially if there's pressure to it, which can mimic the nerve irritation, and it runs in the same exact area as that nerve. So we have to be careful that we rule out those as well, because if that's not taken care of or that's not addressed, sometimes those deep vein thrombosis, those blood clots will actually break free, and they can cause issues anywhere else in the body. So they can cause heart issues, potentially a heart attack or a stroke. So those are, again, big things to make sure we rule out when we're looking at any pain running down the back of that calf, which, again, a classic sign of sciatic symptoms. Now, as we look at the other branch here, he branches off and comes around the outside of that knee, and he wraps around the front. And in the next slide, we'll kind of be able to look a little bit closer at those two nerves there. So the lower branch is here. As we talked about that tibial nerve that runs right down the back. So that's this one here running down the center of the back of the leg. It runs all the way down the back of the leg, and down here, it comes down the inside of the ankle right through here. So as it crosses the ankle joint here, we have what's called the tarsal tunnel. Okay, that's these kind of bands of connective tissue. Another kind of a restrictive or choke point, if you will, for that nerve. If there's a lot of tension or pressure building up in that tarsal tunnel, what can happen is irritation of that sciatic nerve again. So if we have a lot of stress going along the tendons that run in that same tarsal tunnel, we can inflame the area, irritate the nerve, and cause symptoms running up and down the leg. The last portion we have to consider with that tibial nerve is right here where it branches again. It'll branch into what are called the plantar nerves. So we have medial, which is inside, and lateral, which goes to the outside of the other side of the foot. And they run down the plantar or bottom surface of the foot. We have to be concerned here because those can be, especially if we're on our feet a lot, they can become compressed on the bottom of the foot, and they can create symptoms that are very similar to plantar fasciitis. Okay, sometimes plantar fasciitis is actually mistaken for more of a nerve issue of these branches of that, eventually the sciatic nerve. So things we have to be, again, considerate of for people who are on their feet a lot, who may be irritating this nerve at the very end. Okay, now those nerves also transmit any waste products to the end of their nerve, and they deposit that in the tissues down here. So at the end of these nerves, there are waste products that are produced by those nerves that are deposited there and can form inflammation and swelling. Another thing that can further complicate and put compression on those nerves and irritate them further. Now, the other branches that we mentioned were that called the peroneal nerves. They come around, like you mentioned here, after it splits and it comes around the outside of that knee. They come right around the outside of the knee and it branches again. There is a deep branch that comes right down the length of the shin here. There's actually one more muscle that was removed, so you can see that in there. So it's all kind of encapsulated in muscles, just like at the hamstring and calf areas. And we also have this branch that comes right down the outside here, along the outside of the leg. Now, again, in a portion of the population where this nerve wraps around the knee here, it will actually pierce this muscle right here, okay? And when it does that, that can create an irritation, but it also innervates all the muscles along the outside of that leg. Now, a big thing we have to be concerned about here is a severe lateral ankle sprain, okay? So in a lateral ankle sprain, what happens is the foot remains more fixed, the ankle will move out that way, and all the tissues along the outside of that ankle and lower leg will create tension, or they will stretch. When that happens, all these muscles here stretch, and we can potentially stretch and irritate that nerve in there if there's protective tone and there's a lot of force that goes through that area. So if that nerve is already pre-irritated and we irritate it further, we can have a large flare-up of our symptoms. So if we are having potentially some back symptoms, And then we have one of these other issues in either the hamstring, the piriformis, the calf muscles, an ankle sprain. It could be a minor or a seemingly minor injury, but if we already have a slight irritation to that nerve, a second irritation can set that nerve off much more severely than we would anticipate from, say, a minor ankle sprain. Okay, so if we have two irritations of that nerve, the results are exponential almost. So the first irritation, yeah, we recover from that, or we think we do. Then we irritate it a second time, and the symptoms take off again, and they're much more severe that second time. So that just goes to show that we need to make sure we calm the nervous system all the way down to really get rid of the problem for good. So now you might be wondering, with all of these things, what can I do, right? Is rest the option? Is exercise the option? Kind of what is the thing? Now the big thing is that rest is not the best remedy for these types of injuries and issues. We want to make sure we don't irritate things further, but when we rest and we sit still and don't move, we don't really give the nervous system input that it's looking for to help reassure it. So laying down or resting for short periods of time can help with symptom management, but it doesn't promote recovery. Okay, it doesn't help us get any better. It can only help in the short term. So what we'll oftentimes find, and what the research is now showing, is that being more active in a controlled manner actually helps us recover much, much quicker than just resting and hoping it'll go away. Because when we hope something goes away, oftentimes it doesn't, unfortunately. So that brings us to a couple of things that we can try today if we're dealing with some sciatic pain and symptoms. So we can use ice and heat. So both can be beneficial at different times. So what ice can do is it can help provide some immediate short-term relief. Okay, it can kind of give some of that numbing sensation to the area. It can help sometimes reduce inflammation if there is some that needs to be reduced. And it can also help to ease sometimes muscle spasms. Okay, it can help kind of calm some things down and slow down some nerve conduction in the area. Now, if we use heat, what that can do is it can oftentimes provide a soothing kind of a feeling to that leg, okay, to that area or the back. So heat helps to kind of reassure our nervous system, helps it calm it down. It can make us feel more comfortable. Sometimes it helps to increase blood flow, which can help healing. So both, again, can be used depending on the situation and what we actually need to do. Sometimes alternating is good as well. So if we alternate between ice and heat, we can kind of get good benefits of both. But what we want to be careful of is we don't go any longer than 15 or 20 minutes with each. Okay, so if we do too long, we'll actually have what's called a rebound effect. So if we heat for too long, we'll get the benefits of heating for so long, and then we'll have this reverberations where then all those effects will kind of be reversed if we use heat for too long. Or if we use ice for too long, the same thing happens. So in order to avoid that from happening, we want to make sure that we let our body return to the normal temperature before we reapply that heat or ice. And you can do that as many times as you need to or want to, but making sure we only go 15 to 20 minutes max on, then you take it off for the length of time until your body returns to its normal temperature, just to make sure we don't have any of the negative consequences of heat or ice. Now, another option is to get a little bit more active is walking or another low impact exercises. Things like biking is low impact, swimming, those kinds of things. We're not talking about big contact sports or running, those kinds of things, which are higher impact. So those low impact exercises are surprisingly effective because they release what are called pain fighting endorphins, and they help to reduce inflammation by increasing the blood flow to the areas, again, helping to promote recovery. What we have to be careful of is that we don't overdo it. So if we're in severe pain and we continually push and push and push and push through it, that will oftentimes irritate an already irritated nerve. So we can do short amounts of our normal activities within a tolerable amount, but we don't want to push and make things worse. We don't want to aggravate symptoms more. And if we do walk and aggravate our symptoms with that, we might want to look at the actual mechanics of how we're moving, okay, or have an expert look at those mechanics of how you're moving, because that might affect essentially how that works, and how we feel, how we move plays a huge role on if we're irritating that nerve or not. Now, when it comes to sitting, because oftentimes we can't just stand up all day, we have to sit for things. Sometimes it's work, sometimes we just get tired, those kinds of things. So a couple of options for sitting is, if you have a reclining chair, you can try and recline back to take some pressure off that low back. Another option, well, first thing, what not to do, we don't want to sit up straight, stiff as a board. Okay, that's oftentimes the most common evidence or common suggestion when people are saying, oh, my back hurts. They tell you to sit up straight. That's not often the case. Because when we sit up straight, what happens is we're actively using those muscles in the back. So if we're having back pain and we're forcing those muscles to work harder, we're just going to magnify that back pain. So what I'll recommend people do is, if you start in that up tall position, you take a big breath in, and you let out a really big breath, a really big sigh, and kind of give yourself permission to relax. What you'll find is you will almost slouch a little bit. Your shoulders will come down and forward a little bit. Your back will relax. Now, I'm not talking you slouch over like this, okay? It's just a very slight, subtle slouch motion. We don't want to think about slouching. We just want to exhale completely, like you're letting out a sigh. Sometimes even just saying the word sigh will help with that motion, but allow the shoulders to come down, let that back kind of settle in a little bit, let those muscles kind of let go a little bit. And that's a very good sitting position, because it's much more comfortable to maintain, and it helps us relax much better in that seated position, which, if we're sitting for 8 hours a day at work, is a huge thing when it comes to potentially irritating that nerve or making things worse. Now, sleeping is also another very common issue when we're having sciatic or nerve pains. Okay, if it's specifically irritation of that sciatic nerve, what we can do is, if we put a pillow between the knees, that helps to avoid any rotation of the pelvis, especially if we're sleeping on our side. Okay, now another option for us, if it's more the sciatic nerve, because we're always sitting all the time, what happens is we want to shorten. If we shorten that nerve, we can reduce the tension on it when we're sleeping, especially if we like to roll around a lot at night. Those movements might irritate our nerve. So if we actually bring the heels slightly up towards your butt, that actually creates a shortening of that sciatic nerve, and it can help manage in the short term so that we don't irritate things while we're sleeping at night. So especially if you're sleeping on your side, you kind of bring your heels up towards your butt, letting the knees bend just a little bit. That'll take and put a little bit of slack in the system so you don't accidentally tension it if you move around at night. Now, the largest thing that we always want to focus on when it comes to managing sciatica and sciatic type pains is we want to return to our normal activities as much as possible and as much as tolerated. What that means is those normal daily activities are keeping us active. They're continuing to get load through the muscles in our legs and our back that we need to help that recovery, because those muscles need to do their jobs. They need to do them oftentimes better than they currently are. So stopping doing those movements is only going to make that recovery harder and take longer. So if we continue to not necessarily push through the pain, but to be mindful of it and continue to do what we can, that is going to only benefit us in the long run. Now, when it comes to the actual pain management, unfortunately, a lot of people believe that pain medication cures issues and cures sciatica. The problem is it really doesn't. Pain medication isn't going to resolve the root cause of the problem on its own. And there's not a bunch of evidence to support any use of anti-inflammatories or other pain medications for pain relief in the long term, because they don't cause any long-term effect. And what they're finding is the potential negative side effects of a lot of these medications can be quite extreme, from dependence, withdrawal, and addiction, essentially, on a lot of those things. So they don't recommend a lot of prescription medication or medical management based on prescription medications for the treatment of and management of pain. What they do what they do say is if you are going to use those things such as NSAIDs, so anti-inflammatories, or some of the lower dose pain medication, you want to really take into account the potential for stomach, liver, and kidney damage and dysfunction from the use of these medications and the toxicity that they create in those organs. And we really want to factor in other risk factors such as any systemic diseases or any potential organ system issues that we're dealing with genetically or otherwise, as well as other risk factors such as our age. And we want to make sure if we are going to use those things that we're using the appropriate clinical assessment. So we're not just taking the medications and not tracking or managing and looking at how those things are going. We want to make sure we're monitoring for those risk factors, for any damage of the organs. We want to make sure we're looking at the different levels in that area and make sure that we are looking into some protection for the lining of the stomach, because that's another area that is very often damaged with the high use of these medications. Now, when we are using those medications, what they recommend in the research is to use the lowest effective dose for the shortest possible amount of time. So these are not supposed to be a long-term solution because the pain medication is not going to get rid of the problem. They're supposed to be used in conjunction with another treatment method, whether that is, if it's a very severe case, whether you need surgery or not, or whether you need more movement or something to help you get back to those daily movements to help you with that recovery. So if not pain medication, what do they suggest? Well, if things get really intense and very severe, the research is suggesting that an epidural injection would be the main go-to for severe cases of acute sciatica or sciatic pains. And what an epidural injection is a local anesthetic or steroid that they'll inject into the actual spinal canal on that, either the spine or right on that nerve root, right as it's leaving the spine. Otherwise known as like a nerve block is what it would be called there. So with those nerve blocks, oftentimes people have mixed results. And unfortunately, in what we have to be aware of is if they just use imaging to say, this is the spot where the nerve block needs to go, again, like we mentioned earlier, they're just guessing. They don't know for sure. So in addition to an image showing the areas where there might be an irritation or issue, we have to make sure that the person who's going to be administering this injection has done a full clinical exam to understand exactly where the problem is coming from. So that involves looking and testing sensation, that involves checking our reflexes, that involves tensioning and potentially provoking the nerves in the leg to understand what segment things are coming from, okay? It doesn't just involve an image, because with just one image, it's like putting a needle in a haystack, okay? We're not going to find the right spot most of the time. That's why people with these injections will either have short-term results, or they have results that last for a little bit, or it doesn't affect their pain at all. They're likely either in the wrong spot, or they don't have the issue that this can help with. So in addition to that, we want to make sure that with some conditions, we don't use these epidural injections. And that's in the case of the first type of irritation, which is the actual compression. So if we have that physical compression or restriction of the nerve where it's killing that nervous system and causing that damage, this epidural injection isn't going to do anything. They only help with the nerves that are irritated, not the ones that are being compressed and suffocated, essentially. So only when they've had that tension, it helps to calm them down so we can return to more normal activity. Now, if things get so bad where we're considering surgery and nothing else is happening, there are a couple of recommendations in the research as well. So the most common recommendation is considering the spinal decompression. So that's the most common surgery. That's the one that they have seen the most benefit with. That is the go-to surgery. And only if a couple of things have happened, though. They only recommend that when non-surgical treatment hasn't improved the pain or function. And that the radiological symptoms or findings, which again are those neurological signs looking at, basically we're looking at all of the reflexes, the sensation, the muscle strength. If those are all impaired, then we want to make sure that we take into consideration those. And if those are consistent with sciatic symptoms of that compression, then they want to do a decompression surgery. Okay, this surgery isn't going to help with an irritation, only that compression, which is actually suffocating the nerves. What they do also say is they do not recommend any type of disc replacement surgeries. So disc replacement surgeries don't have the same benefit as the decompression surgeries, and they don't have the same positive results in all the research studies that have been done up to 2020. So that's one of the things where we want to steer clear of, especially when we have low back issues and sciatic issues. So avoiding a disc replacement surgery and opting more for that spinal decompression. Now, one of the other common surgeries done in the lower back is a spinal fusion. The research also does not recommend this, but not from lack of positive or negative effect. What they have is there isn't enough research really to indicate whether it's going to be beneficial for the majority of people or not. So what they suggest is, unless you're part of a randomized controlled trial or a clinical trial, they recommend against getting this surgery because there isn't enough known about it. So there's not enough known about those spinal fusions and their long-term effects and their potential risks and benefits to recommend people with sciatica and low back pain from getting those at this time, unless it's more of being included in that clinical trial to understand more about those effects. Okay, so unless there's a potential benefit to science, they're not recommending you pursue that route. All right, now one of the other most common sciatic myths is that you can't prevent sciatica pain. Yes, most people are going to have it sometime in their life, but the thing is, most of the time it is preventable. Okay, so in some cases it's a lot harder than others, but it always is. And it, like I said, it takes sometimes a lot of work to avoid having those kinds of issues and those problems in the future, but a little bit of prevention goes a long way. A lot of the major things that happen is if we stay active, stay moving, if, like we mentioned earlier, those protective tone in those muscles, the more we use the muscles, the less they have to protect because the stronger they are. So if we can move around and make sure we're changing positions and loading those muscles, getting them tension and having them work, what will happen is they don't have to protect as much. If we're focusing on the mechanics that we use, so the way our body moves, if we're moving properly in a way that is going to help prevent any injuries in the future, that's another area that we want to make sure that we focus on. So we're doing exercise as well, we're doing movements properly, so we're not putting our body at a disadvantage or putting us at a potential risk for these issues in the future. Now, another option is making sure that you have strong muscles through the core. So it's one of the largest areas that's underlooked is the variability of movement in the trunk in that lower back. So if the back isn't moving, we get that protective tone around there, and especially those muscles around the spine. And when that happens, that affects all those areas, that segments along the spine. It can irritate those nerve roots. So making sure that the obliques and the core in the front of the trunk, the belly and the abdomen are strong, helps to reduce some of that muscle protection in the lower back. And it helps to improve our ability to move, our variability of movement with day-to-day tasks. So they don't put us at that disadvantage. All right, now, the big question here is, how can physical therapy help with all these things? And the biggest thing is that differential diagnosis. So locating the why, the root cause of what is going on, is oftentimes the hardest thing it comes to when we're dealing with sciatic pain and symptoms, because as we saw earlier, there are so many different things that can affect that nerve and irritate it. Everything from the back, from the hip, we talked about all the different muscles and things that can affect. Yes, we can look up all those things and different symptoms on our own and try and figure that out. But a lot of times it helps to go to the expert who already knows what they're looking for to help rule in and out those different conditions. And they can help narrow it down a lot quicker than we can on our own. Okay, so going to a physical therapist who knows how to evaluate all of those different areas and knows where to look for those things is going to really speed up the process of your recovery. And we all know that when we're in pain, that's something that's critical, is that recovery. Especially if it's keeping us from doing things that we love, okay? From being active, from spending time with our families, those kinds of things. A large portion of the focus is on just core loading exercises, especially if it's more of a back issue, or we're suspecting it's coming partially from the spine or irritation up there, just to improve the movement variability of that low back, to reduce that muscle tone. And that can be done again throughout those different areas we mentioned, working around the hamstrings, around the calves, to restore the normal motor function in those muscles, to reduce some of that muscle tone and protective mechanism from that nervous system, to make that system a little bit more happy and reduce that irritation. Now, one other big thing is reducing the posture, or improving the posture and the range of motion, and changing those biomechanics to make sure that we're moving in a way that's going to promote good movement patterns and not result in potential injury or put us at risk for injury. And again, if we go to the expert to do those kinds of things, what'll happen is they'll be able to look at your movement patterns and help you figure out what potentially is putting us at a higher risk, and maybe take care of those problems before they become problems. Now, there was a study done in October of 2020, and it was looking at people that have sciatic symptoms and their treatment and care. So for a group of them, they went to physical therapy. They were referred there. And another group of them, they sent them to the usual care of primary care physicians, that kind of a thing, without physical therapy. What they found is a fairly large increase in the percentage of patient-reported treatment success with the physical therapy group compared to the non-physical therapy group. So it isn't quite double, but from 27 to 45%, that's quite a sizable increase in terms of the patient-reported treatment success. So there is a quite a significant difference there between getting the help from the expert and then going to usual care, okay? Now, when it comes to that, we can increase that 45% improvement rate higher if we go to somebody who understands more about what the actual cause and the condition is. Now, when I do an initial eval, when I treat a person, initially what we make sure we do is we kind of talk through the whole injury history. We talk through any other potential injuries to make sure that past injuries aren't influencing the current issues and condition. And we're also looking at other factors, as well as the health of the nervous system, the motor function. So if we have somebody who can explain all of the different areas to you and you feel confident with their evaluation, that's going to improve that 45% higher. So making sure you're comfortable and confident with the person that you're going to see is always a critical component of having that care work better for you. So with that said, we do have at Renew Physical Therapy 16 locations in the Great Lakes Bay region. So there's probably one pretty close to you or within driving distance. Like I said, we have experts in all different clinics. So there is going to be someone who can help you if you do need that help. Now, if you're unsure of whether this is the right option for you, or you're still not quite convinced that you can do physical therapy and make it work, we do have a free consultation, a 15-minute consultation we offer. And if that's something that you're interested in, basically what we use it for is to help you make a better decision about your future health. So it's a no obligation consultation. And what happens is we talk through your injury, we talk through the possible cases, and we try and figure out what, or help you make a better decision in terms of what's the right option for you, whether there is a red flag and you need to get further looked into, whether physical therapy is going to help, or potentially whether you're on the right road to recovery and you don't really need our help. Okay, so it's one of those things where if you're on the fence about it, you can contact any of our clinics. I'm sure you've been able to find either the Renew Facebook page or our website. I'm sure you've been on there if you were able to find this webinar, and that's one where you can kind of reach out. Now, like we mentioned earlier, I have some time for questions here. So Kate, what kind of questions have we got today?
Thanks, Russell. We do have a couple questions. Some are recap, which is fine. We'll go through those. Some are a little broad, some are a little narrow, but we'll go through them. And if anybody has a question, you can still submit with the Q&A button on your screen. The first one we have is, are there any specific exercises to help in sciatica recovery other than walking, etc.?
Okay, so walking is a big one, right? But we already know that. Making sure that we're doing our normal daily activities is also pretty critical in terms of just getting up and mobile and active. Now, when we do look at exercises to recover from sciatica, the big thing we want to focus on is what we're doing for 6 hours versus 6 repetitions. Okay, so any exercise of 3 sets of 10, while it can be effective, it's much more important to make sure we're focusing on the actual day-to-day implementation of what we're doing for that longer duration. Okay, I can give you any exercise for 3 sets of 10, and if we only do it once or twice a day, it's only going to make so much impact. But if we can change how we stand, how we walk, how we sit, those things are going to make much quicker improvements and changes than just doing a single exercise. I'm hoping that kind of makes sense there.
Sure. Yeah, that's helpful. We have another attendee who said she's been diagnosed with spinal cord stenosis, so she's wondering if physical therapy might be able to help with that kind of nerve pain.
Okay, with spinal stenosis, again, there is that narrowing of that spinal canal. Okay, in extreme cases, there's that compression on the nerve and potentially damage to the nerve. Okay, in non-extreme cases, there's just a narrowing of the space. It can create some irritation there. There are cases of spinal stenosis where there is still enough space where it doesn't actually compress on the nerve. So without really testing or knowing much more about your specific case, it's hard to say exactly what is gonna benefit and not benefit you. But an evaluation would allow us to check for those neurological signs, so our reflexes, our sensation, and our motor strength. And depending on what we find, what would happen is we either say, yeah, there's a compression of the nerves here that might need to be looked at in terms of surgically, or I'm not seeing signs of any compression. It's probably more of an irritation, and that's definitely something we can help out with.
Wonderful. We did have someone just comment. They said no question, but just want to say good job. Very detailed from anatomy to symptoms, causes, and treatment. So that's
excellent. Thank you. Thank you.
Yeah. Another one, somebody had a hip replacement a year ago, and now they have some discomfort in their front thigh. So they were wondering if that would be sciatica pain.
Okay. So it's not very likely. When we have an injury like a hip replacement is trauma to the body, because they're cutting in, removing a piece of your body and putting a new piece in. So it is a trauma and it is an injury. When we have those things, a lot of structures and tissues move around. And if it was, we said a year ago, I think is what you said, or a few years ago.
Yes, a year ago.
Okay, a year ago, yeah. So it's still in the fairly recent stages. Now, a lot of times our tissue takes, after a big injury or surgery like that, it can take a year to 2 to really remodel and get everything used to the new hip, the new things in there. So having some residual symptoms can be normal. Okay, it can be expected. Those should continue to improve, and they should subside by about the end of about a year and a half to 2 years on most cases. However, it's hard to really say, because every surgery is a little different. Every person's a little different.
Okay, that's helpful. We have another hip replacement question. This person is 8 months out. She said, I was told I have a minor Trendelenburg gait. Is that familiar?
Yeah.
She said, I have symptoms of sciatica, had an MRI that showed no tears in the abductor muscle. Would I still be able to do therapy?
Okay. So if we have what's called a Trendelenburg gait, that's oftentimes kind of a swaying to the side. Okay. Oftentimes it's a sign of weakness in the muscles on the outside or the lateral side of the hip, affecting our ability to maintain stable in stance and walking. With that case, physical therapy can definitely help to improve the motor function of those muscles on the outside of the leg. Okay. oftentimes after a hip surgery, depending on the approach they usually use a what's called a posterior lateral approach, which is going through the gluteus medius muscle and the gluteus minimus muscle, which are responsible mostly for that Trendelenburg gait. So a really good recovery from a hip surgery is going to require some strengthening, some coordination building in the outside of that hip. Definitely something we can help take care of.
Excellent. Okay, this one, it doesn't have a question attached, but I think they might just be looking for some overall guidance, and I'll paraphrase it. Experiencing pain from their glutes all the way down to their ankle on the right side. It's kind of been coming and going from January to March. So they said it goes away, but then it comes back for a short time.
Okay, so it's been going on for 3 months. So oftentimes if we have those symptoms, if it's persisting, if it's lasting, if it's constant, usually it drives people to get care right away. But if it's that kind of coming and going, we tend to think that, oh, if we give it a little bit more time, it's just going to improve. If it's been 3 months and it's still going on, there's some help that needs to be done there. Okay, so that's something where we don't want to continue to suffer on and off with that. What's probably happening is we're doing something to re-irritate or re-aggravate that nerve, potentially a movement pattern that we're using, or potentially something we do kind of infrequently that tends to bring those symptoms back on. I'd encourage you to just kind of think through the movements that you're currently doing, or that you are kind of sporadically doing, or when it kind of triggers those symptoms, and see if there's anything that's consistent there. And if you can't think of anything, maybe kind of coming in for a consult or an initial eval and having somebody look at how you're moving and see if there's anything that we can kind of identify as might be a cause for that.
Okay, great. We did just have one that came in. They asked if sciatica can cause weakness in the leg to the point where they can't put weight on it.
Okay, so that is something that can happen from irritation of that sciatic nerve. Okay, as we were kind of talking a little bit earlier about, there are the two main mechanisms can both kind of create a weakness or loss of coordination. And at its extreme state, we can kind of sometimes not be able to bear weight through that leg if it's very extreme or the irritation is very intense on that nerve. So if we're looking at a progressive weakness where it continues to get worse and worse and worse and worse, it could be some deconditioning. If it's in combination with some other neurological signs like the loss of reflexes, the loss of sensation, we may want to be concerned with a potential compression issue that needs to be addressed immediately. If it's more of the irritation, it might just be a coordination issue where those muscles are really protective of the nervous system because it's been irritated. And what we want to focus on then would be restoring the load through those muscle tissues so that they can, again, tolerate that force and regain some coordination so they can start bearing that weight again.
Great. Someone said they're not sure if what they have is sciatica or not. They said it goes from their glutes down to their right leg, but it feels more like a cramp that doesn't go away. Does that ever present more as cramping?
Okay. So it depends on where down the leg it goes to. If it's just going from the glute down to the knee, it could very well be some of the hamstring protective tone that you're feeling. So like we mentioned earlier, those hamstrings, they can kind of guard, especially if there is irritation to that nerve. So it could be a possibility where that nerve's irritated a little bit, and that hamstring is just trying to protect it from putting any extra load or tension through that nerve. If it's going down below that, again, we mentioned it might be more of the calf muscles where they're trying to protect it a little bit. So it's very, very possible that it could be irritation of that sciatic nerve.
Okay, it looks like we just have 2 more questions unless any last minute ones come in. Somebody asked if there's just like a common amount of time that sciatica generally lasts.
Okay, yeah. So with sciatica, most cases are going to resolve without treatment. Okay, we'll see that improvement rather quickly with just normal daily activities. They'll kind of calm back down. Where it comes into play is in the more serious cases. Okay, so if we've had these symptoms for longer than a couple of weeks and it doesn't seem to be changing or improving on its own, it's probably time to go get some expert advice or help, or look up some solutions that you can try on your own too. Okay. What it comes down to is how quickly we want to take care of these sciatic issues. If we're happy doing the work, the leg work to figure things out and try some experimentation, by all means, go try it on your own. Okay. If you're looking for some expert advice on how to get there faster and have somebody walk you through the process, then come see one of the experts and have us kind of help you out with that.
Excellent. We did just have another comment from somebody who said excellent presentation. So thank you for that. Good job, Russell. And then one last question, just if there's any kind of rule of thumb about whether to try heat or ice first.
Okay. So I usually recommend if it's just started, using more ice, because if it just happened, the likelihood of there being inflammation and swelling is much, much greater. So the ice can help to calm down that inflammation a little bit. Okay. Now the other flip side of that, if it's been a little bit longer, I oftentimes recommend heat first, because heat is one of those things that's kind of soothing to our body and our nervous system. We tend to enjoy feeling warm more than cold. So it helps to calm down some symptoms, especially if they've been lasting for a little bit longer. That's why heated seats in the car feel good. That hot pack on the back usually feels pretty good. We just like being warm. So that's kind of my rule of thumb oftentimes is use what we're comfortable with and what we think is going to help, because oftentimes that's going to be more beneficial than the other one.
Okay, we did just have one more question that came in asking if they need a physician referral to come to physical therapy.
So in Michigan, we have a law that was passed into place a couple of years ago regarding direct access. So direct access allows you to come to a physical therapist without a referral. And what it allows either 10 visits or 21 days, whatever comes first. It doesn't require a physician referral. However, if you need an extension beyond that point, we can help work with your physician to get that extension on those dates. If we are making progress and we just need a little bit more time beyond the 10 visits or those 21 days. Now, the other thing with the direct access there is that you still can use insurance most of the time.
Wonderful. And of course, again, we have that free screening if you're just not sure and you want some guidance on what works with your insurance and what might not. You certainly don't need a referral for that screening. Otherwise, I think that's all we have for questions. I want to remind everybody we'll be sending a follow-up email that will have access to the recording of this webinar. So if there's something you want to rewatch, you'll be able to do that. And it will also have Russell's contact information there for our clinics too. So thank you, Russell.
Excellent. Well, I just wanted to thank everyone for coming out to well, I guess not coming out, but for joining me for the presentation today. As we mentioned earlier, I am the clinic manager in Auburn for Renew Physical Therapy, right next to the ACE hardware. If you do feel after this presentation that I would be a good fit for helping you out with your sciatica, you can give us a call at the phone number there. You can stop out at the clinic, or what you can do is you can send me an email at the email address there, and I try to get back to questions as quickly as I can. And again, thanks everyone for coming out today.
Thank you, Russell.